The MOPEAD project is a European Union funded project. We call it Models of Patient Engagement in Alzheimer's Disease. And the idea was really to be able to do an earlier diagnosis of Alzheimer's disease and change the attitude among people, elderly people living out, to get access to an early investigation. And of course, one goal for us is also to recruit people earlier for clinical trials. And that's why we tested, it was five countries involved. Sweden was 1 out of 5, and it was led actually from Barcelona. So it was Spain, Netherlands, Germany, Slovenia, and Sweden. So, of course, I can only give you a bit of the experience we have from the Swedish investigation, but we have certainly met and discussed everything. So we had actually 4 strategies to really identify memory problems and to do an early and precise diagnosis of dementia. And the strategies were: 1, a web-based online screening. And the second approach was more what we called an open house approach. We advertised to get individuals to come for a sort of screening. And the third part was that we looked on consecutive patients coming to the family medicine office, to the GP office. And the fourth was actually people coming to the endocrinologist, in like a specialty in the hospital, or a GP that was focusing on diabetes mellitus. Because we knew diabetes is a risk factor, and diabetes patients often have some cognitive problems. And so that was a good. And the experience we have from these 4 runs, because then we had a threshold level to see when they were at some risk to be identified as being demented, they were then sent to a hospital-based specialty, mainly geriatrics or neurology or psychiatry, depending on in different countries who took care about the memory clinic assessment. In Sweden, it was sent to 3 geriatric clinics, 1 here in Stockholm, and 1 in the north of Sweden, and 1 in the south of Sweden. And then they did a dementia-specific, type-specific diagnosis in a more extensive investigation, including neuropsychology, including imaging, including cerebrospinal fluid, etc. And then we have a 4th run, of course, that's more to evaluate the data, and we are in that process now to get out some of the results, and we are only ready with the first analysis regarding the health economic outcome, which investigation would be most cost effective to recruit patients with a specific diagnosis. We can say that we are in the phase of analyzing the data for that, and we haven't even thought about the publications for it. But I can only tell you our own experience here from Stockholm or Sweden. And regarding the 4 runs, I think this online screening was a bit difficult, because that was an online testing. Then you have to test the cognitive function of the individuals who are online. And you don't know who it is, because you only get a report that we have a person that screened, so he should actually, or she should be then sent in for a more extensive investigation. And this is really to test a threshold level. So you have to put rather difficult neuropsychological tests. And many felt probably that they didn't want to do anything more. They didn't want to reveal their name. So we had to screen a lot of individuals, but got very few that were announcing their name, where we could call them back and send them to the more extensive investigation at the memory clinic. So regarding cost effectiveness or outcome, I would say that we had to screen too many to get the few patients that we could include for clinical trials. In our opinion is more the open house was a very, very cost-effective approach. It certainly, it was a big interest. We advertised in 2 journals in Stockholm, and the 2 days after, the telephone rang continuously to Gunilla, and the switchboard at the hospital, it's a big hospital, were calling and saying, you cannot have more calls because the switchboard is blocked almost. But anyhow, people who came, they were then very willing to be investigated more if they fulfilled the threshold criteria. So in our mind, that was we learned to know the individuals, and if we call that the run 2, and then the next work package was the full investigation, including the CSF and the magnetic resonance imaging and the neuropsychology testing and the doctor approach. Then I think this is a good way, or in our eyes was a good way. Regarding the third run, that was coming to the GPs, general practitioners, the family medicine doctors. And we could say that we were doing that in the countryside of Sweden, up in the north and in the south. And we had extremely good GPs who did it. So, and many that should be then sent to the next work package in the specialized clinic, they thought the distance to go to the hospital was like 80 kilometers, something, 70 kilometers. And that they regarded the investigation they got by the family physician was good enough for them, and the prescription they got was good enough. So the outcome was not so cost effective as we had expected. Regarding the fourth run from the endocrinologist or those specialized on diabetes, we had not too much experience except in Spain, where that was done by a clinic focusing on diabetes type 2, diabetes in the elderly. And there the outcome was cost effective, but from the other 4 countries, we cannot draw any conclusions on this run. So that was a bit of the results. It's under evaluation, we could say.